Hi, Jody. My name's Colin Fraser. I'm a student physical therapist. How are you doing today?
Good, how are you?
I'm doing well. I heard you've been having some neck pain, and I just wanted to take a quick assessment of your neck. Is that all right today?
Yes.
All right. So first off, we're going to take your blood pressure. Now, for the sake of this video, I'm going to do an automated blood pressure because I don't know where my actual blood pressure cuff is. But normally I would take blood pressure with the stethoscope and an actual signal manometer. But like I said, for the sake of this video, I will be using an automatic. Normal, if I was to use an actual one, I would make sure that the cup takes up about the upper part of her bicep. I would tighten it up. Normally, I would apply pressure until I couldn't feel the brachial artery, and then I would start measuring. But because I don't know where my cup is, we'll just use an automatic for the sake of this. I got 128/92.
That's really high.
It's a little pre-hypertensive. And then for respiratory rate, I had at 14, which is pretty normal.
Is that really bad pressure?
Next, we're gonna take your pulse ox. I'm just gonna put this little doohickey on your finger. I just want you to relax. Pulse ox of 97, looking pretty normal. Next, I would do my integumentary screening, look for any edema, redness, pallor. Nothing's looking too out of proportion as based on this assessment. So I would move on. I would check for any nail clubbing or any pitting edema. Not seeing anything. So next, I would move to the neuromuscular observation. So I would have my patient do some gait analysis. So if you just want to come up and take a few steps, some back and forth. Go ahead and have a seat. And then maybe some functional movements like taking the coat off, coming back to that chair. Nothing seemed too out of the ordinary, so her neuromuscular observation looks good. Next up, I would move with thoracic and cervical. Just some posture assessments. Looks like she has a bit of rounded shoulders. Could be because she works at a desk job a lot. She has some pec major tightness, maybe some weakness in the lower and middle trap, maybe some tightness in the upper trap. Upper extremities, checking for any symmetry. Nothing looks too asymmetric. Facial symmetry looks fine. And next, I'll move to palpation of the different areas of her neck. So first, I would palpate for her cervical paraspinals, and doing that, keeping her head covered. I would apply some pressure, and then moving down her paraspinals. Is there any pain with that, Jody?
No.
Okay. And then go ahead and cross this arm on this shoulder. Perfect. Next, I'll move my way down for upper trap. Any pain with that?
No.
All right, good. And then moving back to levator scap. Coming from the acromion, I would move medially along her scapula until I felt some slack moving out of the way to indicate for levator scapula. And usually a dog isn't there to distract the camera person. After that, I would move to her thoracic paraspinals, where coming medially from the levator scap, I would press and slide, asking for any pain. pain?
No.
Okay. Next up, I would assess for her first rib. So coming across the clavicle, once I can palpate for it. Got it right here. And then moving down here, you can feel for the second one. I would have my patient take a deep breath. And then as she exhales, I push down. And then feel for that, any difference in the tightness. Go ahead and do it one more time. Exhale. Okay. And then for scalenes, I would just move a little bit posterior, have her take another deep breath. And then right there, I can feel the tightness of the scalenes. Go ahead and exhale. So next up, I would do the Canadian C-spine rules. You're younger than 65, so that would rule out any imaging. Where are you right now?
I'm at the doctor's office.
Okay. What day of the week is it?
Sunday.
And who am I?
Colin Fraser, physical therapy student.
Okay, that would mean she's alert oriented. Another Canadian C-spine rule. And then after the palpation, there was no tenderness or pain, so that would essentially rule out any needing for imaging. So, Jody, with this neck pain, have you had any dizziness, any drop attacks, any double vision? Do you have problems speaking or any trouble swallowing?
What's a drop attack?
Where you drop down, you just start feeling wonky.
No.
Okay.
She's down the road.
Any of those other symptoms?
No.
What about some anxiety?
Yes.
Okay. And what about does your walking feel weird lately?
No.
Does it seem like it's weird? Okay. Any numbness?
Yes.
Okay. Where did you have the numbness?
In my arm.
Okay.
My hand.
Okay.
Along here.
Any nausea?
No.
Okay. And have your eyes been like acting weird, like they've been going up and down?
Like this?
Something like that. Yes.
Yes.
Okay. So this is kind of leading me towards that this could be a radicular pain, but I will get into that further with some, with my special testing. So she has no signs of. How did this start? Was it an accident or what? How did this?
Just over time it started hurting.
And she doesn't have any signs of myelopathy. No, it looks like her condition wasn't trauma related, and no previous conditions. So I would not need to do the sharp pursor test, but for the sake of this, I will present the sharp pursor test to test for the transverse ligament stability. Over here.
Like this way?
No. Scoot towards me.
Oh, sorry.
So palpating for C2, bringing her hair up, coming into the suboccipital fossa. Does that feel like bony? Yep.
Yeah.
And go ahead and sit up straight, nice and straight. I would apply a forward pressure with my right hand and a backwards pressure with my left hand, checking for any instability, any reduction of symptoms, and if not, any pain.
No.
That would be a negative sharp pursor test for transverse ligament is intact.
Great.
So next we're going to do some cervical range of motion. So I'm going to go ahead and lock down the CT junction, the cervicothoracic junction. Just applying a downward force, and I want you to go ahead and tuck your chin down. And I would apply an overpressure. Any pain with that?
No.
Okay. Go ahead and look up straight to the sky. Apply an overpressure for extension. Any pain with that?
Nope.
And then for rotation, go ahead and turn your head to the left. Applying the overpressure. Any pain?
Nope.
Okay. Go ahead and turn your head to the right. Adding the overpressure. Any pain?
No.
All right, good. Go ahead and bring your right ear down to your right shoulder. Adding the overpressure. Go ahead and bring your left ear down to your left shoulder. Any pain with that?
No.
Okay. So that's for her range of motion. And next for her thoracic range of motion, what I'm going to do is come over to the side to block off her right leg for any lumbar movement. Go ahead and cross your arms. Go ahead and turn your body to the left. Stabilizing, I'm going to add some overpressure. Any pain with that?
No.
Okay. Coming on this side, we're going to have her rotate towards the right. Adding the overpressure. Any pain with that?
Oh.
A little tightness.
Yep.
Okay. Alright, so now we're going to assess some shoulder range of motion. So can you go ahead and bring your hands up straight like this? Okay. And bring it down up to the sides. Okay. And next we're going to do some shoulder and elbow range of motion. So go ahead and bring your, can you bring your, yep, just like you're curling. And then go ahead and bring them down. Perfect. Go ahead and with wrist flexion, go ahead and bring, yep. And then bring them down. And then can you bring your palms to the floor and turn your palms up. Perfect. So next we're going to do some neurologic screenings. So the first neurologic screening we're doing is the Sperling's test. You can go ahead and relax. I'm going to have my patient keep up straight. You scoot a bit closer to the edge. Perfect. What I'm going to have my patient do is slightly laterally flex her head about 20 degrees. Go ahead, I got you. And then I'm going to stabilize here. Add pressure down. I want you to know if you feel any pain. Any pain?
No.
Okay. Moving to the opposite side. Go ahead and relax. I got you. Stabilizing here. Adding downward pressure. Any pain?
Nope.
Okay. Good. Next, we're going to do the quadrant test. So, I'm going to have you basically bring your head back and look over your left shoulder. And then adding pressure. Any pain?
No.
All right. Can you go ahead and look over your right shoulder? Up and over. Go ahead and going down. Adding that pressure. Okay. Any pain?
Nope.
Okay. Perfect. So next, we're going to assess her myotomes and dermatomes. So can you go ahead and bring your arms straight out like this again? And don't let me push into my hands. Go ahead and push into my hands.
Okay.
Okay, relax. Keep your arms like this. Don't let me push down. Okay. You go ahead and push into my hands. Alright. And go ahead and squeeze into my fingers. Alright, perfect. And now for dermatomes, go ahead and relax.
So my guide dog has something. Can I get it from her real quick?
I got it.
Okay, thank you. She's my therapy dog. Thank you.
She's a cute dog, that's for sure.
She's feisty.
All right, go ahead and relax, and I'm going to go ahead and touch your arms and your hand. I just want you to tell me if any of them feel different.
Okay. Nope. Nope. Nope.
You go ahead and relax. You don't need to.
Okay.
Just keep it all natural.
Nope.
Okay. So her myotomes and her dermatomes are looking pretty normal. So that means that any of her pain, maybe that numbness and tingling, it's not as severe. It doesn't affect her dermatomes or myotomes. So next up, we're going to test her reflexes. So just go ahead and relax. And actually, can you push into my hand? Okay. This is relax. I got you. This is testing for C5. Okay. Now for C6. Okay. And for C7, go ahead and relax. I got you. Just relax. Okay. Her right-sided reflexes are looking good. Now for the opposite side. Go ahead and push into my hand. I got you. I'll show you how. Go ahead and push into my top hand.
Oh, sorry.
Okay. And then also here I can do the inverted supinator test. Looking for any abnormalities. And it's all looking normal, so that would be a negative inverted supinator test. Go ahead and relax. And the reflexes on the left side look pretty normal as well. So next I would do the Hoffman's test. So just go ahead and relax. I got your hand. Holding this joint here, I'm just going to flick at the third digit, watching for any finger thumb flexion. Okay.
Am I supposed to have thumb flexion or
Nope.
no? Okay.
This would be a negative Hoffman's test.
What is the Hoffman's testing for?
Any sort of MS or any kind of upper cervical problem.
So you don't want to see my thumb move?
Correct. Alright. Next up for clonus, go ahead and relax. I'm just doing some wrist extension, seeing if she would replicate it without me pushing. Okay. Next up is the Babinski test. I'm going to have my patient remove one of her shoes and socks. I'm going to apply this pressure, and I should see some toes curling. If I see them fanning out, it might be a sign of some upper motor neuron problems. Okay, she's getting that flexion so it doesn't look like her upper motor neuron problems are not there. And then I'll move to maybe some MMT, depending on what the history and exam would indicate. Maybe some additional testing. Alright, and for the next step, I'm going to ask the patient to lie supine on her back. So first up, I'm going to do presenting a distraction of her head. I would be asking if any of these symptoms would go away afterwards after I provided the distraction. Is that symptoms going away? It does. It's positive. Any pain with this?
No.
Okay. Next up, I would do some stretches for the upper trap, levator, scapula, and scalene. So I'm going to ask the patient to scoot a bit forward.
Towards you?
Towards me, please. I'll take your glasses off for you.
Thank you.
So for upper trapezius, I will have the patient in flexion, side bend, and rotation towards the opposite side. And then I would provide a downward distraction force on her scapula to stretch her upper trapezius. Feeling that stretch?
Mm-hmm.
Okay, now for the opposite side. Okay, feels good, she says. Next, for levator scapula, instead of doing a opposite rotation, I will do a same side rotation. And then for all the stretches, essentially that downward force on the scapula. And then for the scalenes, it's similar to the upper trapezius, except I'm going to ask my patient to do a chin tuck. I got you. Just relax, I got you. And then rotation, or side bend and rotation similar to the upper trapezius. Relax. Okay, and now we're doing some cervical gliding and first rib assessment. So, for the lateral glides, coming off of her spinous process of each one, I will then do a lateral glide. Any pain with that? Okay, and then just moving down, I would keep hitting the next one. Any pain? Any pain? Okay. Moving down to 6. And then 7. And then for the first rib assessment, kind of like picking up the slack on her upper trapezius. I would then add a downward force on the first, it'll be on the second MTP. Then deciding the downward force, I'm feeling for any hypomobility or any pain. How's that feel?
Good.
Okay. And then I would repeat this process for the opposite side. And then lastly, for supine, I'm going to do the upper limb tension test. So for this, I'm going to rest You want to scoot to the opposite side, please? Scoot to this side.
Oh, sit up or lay down?
Nope, stay lie down.
Okay.
So with this, I'm going to apply a downward traction on her scapula, keep her hand up, and I just want you to tell me if this movement I'm about to do reproduces your symptoms, okay? Go ahead and relax, I got you.
Hi, friend. No, I'm good.
Tightness on your elbow though?
A little bit, yes.
Okay.
Hi.
Then go ahead and scoot to the opposite side, please.
Sure.
And then same process, hand over hand, pressing down on her scapula, and adding that external rotation, wrist supination extension, and if need be, some elbow extension. Feel the tightness?
Yep.
All right. So then, depending on what the findings would dictate, I would do some mobility, maybe some passive range of motion, maybe some additional tests. And then lastly, I'm going to ask the patient to lie prone, so go ahead and lie on your stomach. And we're just going to do some central and unilateral UPA glides, or 8 PA glides. So for finding this, coming down from the suboccipital fossa to seat 2, right there. For a central PA, I'll do a thumb over thumb, and just add that downward force, asking if there's any pain here.
Nope.
Okay. And then for a unilateral PA, I will come just off of it, move muscle off. When I feel like a little P, I'm on the facet. Pick up the slack on the same side, and just add that downward force again. Any pain?
No.
Okay. And then for the opposite side, and then I would continue on from there to C3. Any pain?
Nope.
Slack. And I would continue on with that for the cervical and the thoracic in the same fashion. And that's an upper quarter screen.